In a normal lung, let's demonstrate this in this diagram. Here is the lung, the pleural cavity. In a normal lung, the mean intrapleural pressure is -5. Mean intrapleural pressure is -5 cm water. This is before what? Before you inspire. This is before inspiration. Before inspiration. If I'm to measure the mean pressures in the lung, the intrapleural pressure will be -5 and the recoil force will be +5. The recoil force will be +5. The recoil force will be in the wall of the lung, +5. And at this time, the alveolar pressure is equal to 0. Let's say that this is a little alveolus here. A little alveolus. The pressure in the alveolus is 0. Now, why is the pressure in the alveolus 0? 0 atmospheric pressure. Why is that so? The alveolus is connected via the bronchiole, bronchus, trachea, nostril to outside. Outside, we standardize this as being 0 atmospheric pressure. So therefore, because they are connected, equilibrium will be established. So the alveolar pressure before I inspire will be equal to atmospheric pressure outside because they are connected. Now, when the lung has these pressures that we have just described, we can say that this is occurring before inspiration. We can say the lung is in a stable state of equilibrium. It's stable. It is not expanded. It's stable. It is just before inspiration. One of the questions I ask, what would you expect the lung volume to be? The lung volume will be FRC. Remember, what is the lung volume before you inspire? Normally, FRC, the volume that remains in the lung after normal expiration. Now, let's suppose that we are going to inspire. How will this affect the pressures in the lung during inspiration? Let's use this diagram to demonstrate that. Inspiration is going to take place now. We are going to inspire. I want to recall to you a law you studied in physics way back, those dark days of physics. You learned that there was a law, Boyle's law, that pressure is inverse to volume if we keep temperature constant. Remember that law? Good. We will use it now. During inspiration, we are going to contract. We are going to contract our diaphragm. When we contract our diaphragm, the diaphragm will pull the lung downwards. As it pulls the lung downwards, this leads to the increase in thoracic volume. Therefore, we will have a decrease in pressure in the thorax. Volume is inverse to pressure. In the beginning, we said that the intrapleural pressure, mean pressure, is -5. Now that the lung is being expanded, pulled downwards by the diaphragm, the intrapleural pressure now will become even more negative because we will be decreasing the pressure in the thorax as we expand the volume, and it goes to less than -5, let's say a mean pressure of -8. So now the intrapleural pressure has become more negative. And what did we say? The more negative the intrapleural pressure, the more it expands the lung, so that now the lung is being expanded by the more negative intrapleural pressure. Now, as the lung expands, what happens to the recoil force? We said that the recoil force in the beginning was +5. Like blowing the balloon as it expands, what will happen to the tension in the wall of the balloon and the lung as it expands? The recoil force will now go to about +8. When the two are equal and opposite again at the end of inspiration, now we have a dynamic state of equilibrium in the lung. In other words, the lung, the two forces are equal and opposite. There is no more expansion. There is no collapse. So now we are in what we can call a dynamic because the lung is inflated state of equilibrium. More importantly, what is happening to the alveolar pressure? Now, this is what I want you to pay attention even more to. The alveolar pressure. We said at the beginning the alveolar pressure was 0 before inspiration. Remember that? It was equal to atmospheric pressure outside. Now the same law applies to the alveoli. As the lung expands, it pulls the alveoli with it. So the alveoli are also expanding. So the same rule applies. Pressure is inverse to volume. As we increase the volume of the alveoli, what will happen to the pressure in the alveolus? It will decrease. So in the beginning it was 0, so now it goes to what? -1. So immediately what do you see we have? Outside it's 0, atmospheric pressure, standardized. And inside the alveoli, because of the expansion, the alveolar pressure has now decreased to -1. We have a pressure gradient. This is how air enters the alveoli. Not because you snuff it in. You could snuff it in all you want. You are just putting it into the conducting zone. For it to flow from conducting zone into the alveoli, I must have this pressure gradient. So this is how now the air enters from high to low pressure. This pressure gradient is essential to maintain flow into the alveolus. So during inspiration, we are developing this pressure gradient, allowing the air to flow from conducting zone into the alveolus. That means as the air flows into the alveolus, what will happen? In the beginning, we are at 0. Now we are going to -1. As the air continues to flow into the alveolus, it brings pressure with it, and eventually at the end of inspiration, the alveolar pressure reverts back to 0, equal to atmospheric pressure. When this occurs at the end of inspiration, flow comes to a stop. There is no pressure gradient. So therefore, question, when would you expect the greatest airflow into the alveolus? Of course, mid-inspiration. Why? That's when we will have the greatest pressure gradient. So anything that interferes with this pressure gradient will interfere with alveolar filling, with alveolar ventilation. In other words, we can say, therefore, that anything that interferes with the flow of air as it goes from 0 to -1, anything that interferes with the alveolar pressure 0 to -1 and eventually back to 0 at the end of inspiration, any pathology that decreases the ability to develop negative alveolar pressure can be referred to as a restrictive disease. Definition of a restrictive disease, therefore, is loss of ability to develop this negative alveolar pressure. If there is no negative alveolar pressure, there is no gradient, there is no flow. Can you give me some examples of restrictive disease where this can occur? Pathology. Did you say fibrosis? Very good. Another one, asbestosis. Very good. Siliconosis, sarcoidosis, and anything that ends in osis. The osis is to restrict. So therefore, all of the osises of the respiratory system are restrictive diseases, so to speak. One of the questions I asked was, in a patient with fibrosis, pulmonary fibrosis, which of the following statements is most appropriate? A loss or decrease in the ability to develop negative alveolar pressure. Correct. The fourth question that I raised was at the end of deep inspiration, what would you expect the alveolar pressure to be? +2, +1, -2, -1, 0. Of course, standard units of pressure. At the end of inspiration, the alveolar pressure goes back to 0. So the answer should be what? 0. Now, in an exam, I've seen students, when they're answering this question, I know when this question is being asked, what is the alveolar pressure at the end of deep inspiration? I see students taking a deep breath and then poke their abdomen to see what's the pressure there. Say, whoa, that's a lot of pressure. And they choose +2, the highest pressure. The exam did not ask, what is your abdominal pressure? Ask, what's your alveolar pressure? There's a big difference there, isn't that so? So therefore, we started out by asking 4 concepts that we want to clear about. Lung volume, when the recoil force is +5, intrapleural pressure is -5. Answer, FRC. When would you expect the greatest airflow into the alveolus? Beginning, middle, end, or equal throughout? Answer, the middle. Third question we ask, what is the expected alveolar pressure at the end of inspiration? 0. And the clinical question from all of that is, what would you expect in a patient with pulmonary fibrosis vis-a-vis the pressures in the lung? Most importantly, this patient will lose the ability to develop negative alveolar pressure. Now, what will happen in expiration? In expiration, we can say that the opposite will take place. If this represents the lung, during expiration, we are relaxing the diaphragm. And when we relax the diaphragm, what will happen? We are going to lose volume. Remember, pressure is inverse to volume. So now volume will decrease, so pressure will increase. So what will happen to the intrapleural pressure? At the end of inspiration, the intrapleural pressure, you recall, was -8. Now that we are losing pressure, it reverts back to -5 during expiration. What will happen to recoil force? We said at the end of inspiration, recoil force mean pressure was +8. We're using this number to illustrate. As the lung collapses, when the recoil force is greater than the intrapleural pressure, the lung collapses. So at this point here, this will cause the collapse of the lung. At this point in time, the alveolar pressure at the end of inspiration was 0. Now that the alveolus is being collapsed, pressure is inverse to volume. The alveolus, the pressure was 0, will now go to +1. As the alveolus collapse, Boyle's law, smaller volume, greater pressure. It then goes to +1. Outside, we said, is at 0 atmospheric pressure standardized. We now have a reverse pressure gradient between the alveolus and outside. And this is why air leaves the alveolus, because of this pressure gradient, not because you blow it out. You're blowing it out from your conducting zone, but it seeps from the alveoli into the conducting zone because of this pressure gradient. As the air leaves, the pressure then reverts back to 0. Therefore, we can conclude that any pathology that decreases the ability of the alveolus to develop positive pressure can be referred to as an obstructive disease. So in other words, an obstructive disease is loss in ability to develop positive pressure. Can you name some pathology? Can you give me at least a couple of pathologies where the patient has lost the ability to develop positive pressure? Are you saying emphysema? Very good. Asthma, yes. Chronic bronchitis, yes. That's why they're all called COPDs or obstructive diseases. But the classic one is emphysema. Why? Loss of elasticity in the wall of the lung, in the alveolar wall, the alveoli cannot collapse. So therefore, they remain bulbous, expanded. They have lost the ability to develop positive pressure. And that is why the air does not leave the emphysematous alveoli. It remains trapped. And that is why when we percuss, we have what kind of sound? A hyperresonant sound. And that is why with time, this patient is at risk for a barrel chest, as the alveoli and the lung pushes out further and expanded, loss of ability to develop the positive pressures. In chronic bronchitis, the same thing, because of the occlusion of the airways, trapping air into the alveoli, forcing the alveoli to be expanded, and with time, losing the ability to develop the positive pressure. So we can understand now the etiology of the pathology in terms of obstructive disease. Now let's summarize everything we have said so far on the mechanics in inspiration and expiration and the changes in alveolar pressure in terms of these graphs. Let's understand these graphs. I'm sure you've seen these graphs 100 times in every textbook and in every handouts given to you in class. First of all, when we look at this graph, as you can see in the first part, we are describing volume, tidal volume. Notice inspiration and expiration. Inspiration, we are starting with 0 and going to 0.5 liters, 500. This is the volume of air that is coming into the lung during inspiration. We said that normal inspiratory volume is 500 mils. Now, why is the air coming on or during inspiration? What's happening to intrapleural pressure? At the beginning, intrapleural pressure, baseline mean pressure, is -5. At the end of inspiration, we said that the mean intrapleural pressure will go to about -8. So therefore, during inspiration, intrapleural pressure gets more negative from -5 to -8. As this occurs, what will happen to flow into the alveolus? As you notice, at the beginning of inspiration, flow is 0. But during inspiration, flow will go from 0 to about 0.5 and eventually back to 0. We can understand this especially if we match it with the changes in the alveolar pressure. Let us look at the alveolar pressure. We said that the alveolar pressure during inspiration at the beginning is 0. In mid-inspiration, it goes to -1. It goes to -1. Notice when the alveolar pressure is -1, that's when we're getting the highest or the greatest airflow into the alveolus. As the alveolar pressure reverts back to 0 at the end of inspiration, notice flow then goes back to 0. So we now can understand this graph, and the opposite, of course, in expiration. In expiration, we are starting with a volume of 500 mils, and then we are at the end of the expiration, we go back to 0 tidal volume. Intrapleural pressure at the beginning of expiration is -8 and then reverts back to -5. Flow. Again, notice flow is maximum during the mid-expiratory cycle, flow out of the alveoli. And this coincides when the alveolar pressure is approximately +1. When the alveolar pressure is +1, the pressure gradient is the greatest. So this is when we will have maximum flow out of the alveolus. Of course, at the end of expiration, the alveolar pressure reverts back to 0. So now we can understand this graph based on the mechanics that we've studied that involves respiration.